All right, so thanks everybody. I'm Jason No. I'm program director for the HPM Fellowship here at Kaiser Permanente. We're based in Fontana, which is about an hour east of LA, and just happy to be part of all this cavalcade of program directors who's giving boot camp lectures. We'll want to talk about dyspnea management and also transition that into a bit more nuance with palliative extubations as well. So just to talk about the dyspnea and palliative care, what that means, what are some strategies for dyspnea relief, uh, things to keep in mind when you have to talk to families about palliative extubations, and I'll just leave some room for questions at the end. It is kind of hard for me to check on the chat, so I'll keep an ear out though if any questions come out.
I'll interrupt if there's anything really important.
Will do. Thanks, man. So it's always good just to start with defining it. So if you look at the American Thoracic Society definitions, dyspnea is subjective breathing discomfort and sensations that vary depending on how much intensity a patient's feeling. And really what it comes down to is there's a supply and a demand mismatch, where someone has an increased respiratory drive, that desire to breathe, they just don't have the capacity to provide that. And where the respiratory drive can come from really pulmonary, cardiac, cancer, all these different diseases will stimulate your pulmonary receptors in your airways, your bronchi, your lungs, even the surrounding diaphragmatic muscles. And all these things will send signals to the brain centers in your pontine medulla area that, hey, there's a lack of oxygen, a lack of respiration. I'm getting concerned, so we need to increase your respiratory drive to make up for it. And so the brain will then send motor commands to try to generate more respiration. And that usually leads to more tachypnea, more deeper breathing, or use of accessory muscles to compensate for that diminished capacity. But then in serious illness, a lot of times the lungs and the muscles, they're just unable to meet the demands. And hence you have that heightened sensation leading to dyspnea. And we really see dyspnea very commonly amongst our patients with serious illness that palliative care touches. So a lot of us work majorly with cancer patients. So a lot of them, whether it's from lung primary or from metastases, about 50 to 70% of patients will have cancer causing dyspnea. As you might expect in COPD patients, when the primary pathophysiology is a lung issue, over 90% of them will have dyspnea. CHF patients, over 50% will. And even those with systemic illness of other sorts, up to a quarter of them, without any known cardiopulmonary process, will have some dyspnea too, whether it's they just subjectively feel it or it's a side effect from, say, fatigue. And like other symptoms, whether it's pain or nausea, really dyspnea can often worsen in the last 6 months of life. So up to 90% of patients at their end of life will have some dyspnea. And that is part of the worsening symptom burden, along with pain, along with nausea. And we really want to know how to treat dyspnea well so that when it does decrease your quality of life, we have some tools at our disposal to help with that. But where does it start with is a history and physical. And I really love this concept of total dyspnea because if you might have heard of the total pain concept from James Cicely Saunders, where you have the physical, psychological, social, and spiritual components contributing to one's total sense of what is the pain they feel. Total dyspnea brings back that it's not just about the physical part, about that increased respiratory drive, decreased capacity, causing that physical symptom. It's also the psychological, social, and spiritual distress too. So you have the anxiety that might be contributing to someone's sense of dyspnea. When you've seen someone have a panic attack, they may often say, "Oh my gosh, it feels like I just can't breathe." Spiritual distress too, just thinking about, I am suffering why I'm in such distress, why can't I get a good breath in? And even like with family too, whether it's trying to navigate what your new reserve might be at home with how can I take care of the house like I did before? How can I keep up with the chores or take care of my child the way I did? And even, gosh, a couple of days ago, we were talking to someone that had a 1-year-old that they're trying to keep up with, but more and more that dyspnea really disabled them from spending time with the 1-year-old that they had just birthed through surrogacy. So coping with the social, the emotional aspects of dyspnea are also really important too, along with the physical. So dyspnea overall, everyone experiences it uniquely. Everyone has their own personal perception of their dyspnea, and really it's a patient-reported symptom, just like pain. And it may not correlate with findings of how hypoxic they are, how much their partial pressure CO2 is, or how high the respiratory rate is too. So something to keep in mind when you're asking about just, how their dyspnea has been. And how do you describe it then? So really, because of the subjective nature of dyspnea and just knowing what we had just learned about from total dyspnea, basic question is, hey, just how do you feel? You know, subjective reporting is one of the biggest ones where do you feel short of breath? Do you feel less able to breathe? Has it improved with our treatments? And that's really just an easy way that anyone can ask about how the breathing has been. The activities of daily living, or ADLs, are another important way for people to really understand how has this dyspnea disabled your function in life? How has it become a barrier to the things that you want to do in your daily life? So questions you can ask include, do you have more good days where you can talk, watch TV, walk around to make food or eat? And that's another sign too. Scoring systems can be useful. Typically, in our clinic, we do have them as part of our workflow. You can also use these two as part of research projects too. So one commonly used one is the Edmonton Symptom Assessment Scale, or ESAS. And they rate dyspnea on a scale from 1 to 10, basically, that you can keep tracking for subsequent visits after you tried some various interventions. And there are some prognostic scales too, such as the Bode scale. It's really used to determine prognosis of COPD patients, but this is key though. It's not when they're in acute exacerbation. When they're hospitalized and for acute exacerbation of COPD, that goes out the window because they're in a different serious phase of their illness. But some of the descriptors that you might hear from patients may include different subjective ways of describing like, what they feel. And so let's say they have difficulty with moving air in and out of their lungs. They may say, hey, I feel my breathing is just more rapid. I just don't feel like I can take a full breath in. If it's some increased effort, they may say, I just feel like I can't get enough air. I'm just trying to breathe more. It takes more effort for me to breathe. And if it's just overall, this dyspnea is just really severe, just generally distressed, makes it, I just feel like, gosh, I'm just suffocating. So there's different descriptors that you can fit into your model of how do I address this? How do I assess this?
Yeah, that's a 1099. What is this? 1511 enter.
Maybe. Okay.
Um,
Let's see. No.
one
So
five
etiology of dyspnea. So
one.
with the breathe mnemonic, it's useful to think about the underlying etiology. And I really like the mnemonic because it helps you organize your differential of, okay, we have this patient with subjective dyspnea. They're suffering from it. What are some things that we can think about and possibly correct to improve how they're feeling? And to breathe really comes first B is bronchospasms. May they benefit from inhaled bronchodilators, albuterol. Vowels it just means consolidation from pneumonia. Can they benefit from antibiotics? Effusions, did they have pleural effusions that might benefit from draining them? Or the ESA stands for embolism. Did they have pulmonary emboli, which is very common amongst our cancer patients who are in that procoagulable state. So could they benefit from anticoagulation to stop new clots from forming and potentially decrease amount of clot burden they have right now? A is for airway obstruction. Is there an actual tumor blocking a bronchi? Is there a phlegm that we can suction up? Do we need to consider other modalities such as palliative radiation or tracheal stents if pulmonology can put one in? T is for thick, so closest thing we can do is thick secretions. Can they benefit from mucolytic agents, nebulized saline, things that can try to decrease the amount of phlegm they're producing? Or H is for hemoglobin. So anemia with low hemoglobin can cause the feeling of dyspnea to happen just because they don't have enough oxygen reserves in the red blood cells. Keep in mind there are other causes too that breathe may not cover, including just good old fatigue that's making you feel short of breath and tired. So multiple sclerosis, cancer fatigue, like talked about before, ALS can cause that too. And then just keep in mind that as your disease progresses, a lot of the targeted treatments that you might think about with these etiologies may become less effective and more risky. So as someone's disease progresses, the risk-benefit ratio shifts. And as Mel had said, you really have to think about, is this worth the risk?
Or whatever LLC.
And overall, symptom-based management of your dyspnea may need to take precedence later on. So
Hey,
that's one of the,
Jason, there's a
yeah,
question about how to assess nonverbal patients if they can't describe or quantitate using some of those mnemonics.
yeah, good question. I can be a mannequin. So imagine that I'm nonverbal. There are certain physical signs that you have to pay attention to when they're nonverbal. So easiest one to see is really tachypnea. Watch the respiratory rate, time it yourself, or use the one that the pulse oximeter is giving. So just that rapid, usually more shallow breathing can happen. And oftentimes what you want to look for is use of accessory muscles too. So when they're struggling to breathe, when they have a lot of dyspnea, you'll see that there'll be a lot more use of their accessory muscles here. You'll see more costal retractions in the lung, in the rib areas. They're trying to suck more air in, and they're really using their coastal muscles in between the ribs to breathe. So you see a lot more sucking in and out, almost like a neonate struggling to breathe in NICU. A lot of diaphragmatic breathing might happen. So when the costal muscles are just not enough, when they have severe COPD, that's really worsening the amount of contractility their chest cavity is facing. They may resort to using that big old diaphragm muscle. So a lot of belly breathing is what they would compensate for by using that diaphragm. Look for retractions too in the sternocleidomastoid muscles and under the clavicle. So a lot of deep sucking and a lot of use of the kind of the muscles here in the clavicle. Those are all the signs of increased respiratory distress and a sign that you might need to compensate for that. Does that answer your question?
Yes, it does. And yeah, I work with kids too, so we would use those signs with children as well. Thank you.
Of course. Yeah, kiddos may have more. I think they usually grunt more compared to their adult world, but also some things too to keep in mind. Good question. Uh, Good timing. I wanted to open it up to the chat and see what kind of strategies are you familiar with to relieve dyspnea? Any thoughts? Yeah, good old fans, hand fans, good. Morphine. All right, all these. So we'll talk about them, and thank you for participating. So some current strategies that we've looked up, really non-pharmacological approaches are useful. So a lot of times it's about repositioning. So the orthoptic position is useful. It's almost like tripoding, like you see here on a stack of pillows, if they're able to sit up or to put their hands on their thighs. And it comes back to orthopnea. When you have that shortness of breath, especially when you're lying down supine, commonly seen in CHF patients who need to sleep on 2 or 3 pillows. In this case, we're just helping to go and do tripod positioning or lying on stack of pillows so that you allow the chest walls to expand more greatly. And then you're able to utilize more of the accessory muscles to help with that lack of contractility from the chest wall. Other things you can use include relaxation techniques. Being mindfulness is really helpful to reframe the way you're thinking about dyspnea. It is kind of hard to practice when you're actively dyspneic, but it's more mild, intermittent throughout the day. Mindfulness, calming music can help. Remember in the social domain with total dyspnea that having friends or family around to support you can often help with that sensation. And just remember that there's a spiritual component too. Having a good chaplain, spiritual support can really support you through that. The non-pharmacological approaches, perfect. We got fans. So fan therapy is very commonly used. The theory is you blow air on one side of your patient's face. And the theory is that that directly stimulates the facial nerve V2 and V3 branches of your trigeminal nerve to then also trigger reflex relaxation in the brain. The nasal mucosa, your pharynx also has a part to do it too. And you can see that lovely standardized researcher who gratefully modeled that for you in one of the research papers here. Study-wise, the latest study from Kako in 2018 showed that when you did this fan therapy on one side of the face, in as little as 5 minutes, your mean dyspnea score could decrease meaningfully by over 1 point. And what I loved about the study is just to make sure that it was really working, they just blew the air towards their legs instead to see if did it really work. And no difference in the legs. So it seems like that theory where the relaxation of the trigeminal nerve, the nasal mucosa, the pharynx really did have something to do with it. So something that's often used in home hospice, and you might also see it used in inpatient settings too, depending on the hospital and what kind of fan availability they have. And next up, really, it's opioids. Opioids are the first line for pharmacological management of dyspnea. And why do we think they work? So there are two mechanisms that are thought of. One is really reduced correlate discharge. What does that mean? So remember that in the diagram before, you had all these lung bronchioles, muscles triggering feedback to the brain saying that, hey, there's a problem with I'm not getting enough air, oxygen in me. And so what we think opioids do is they decrease that responsiveness of that brainstem to all the respiratory stress that's happening, and thus lowers the respiratory output and the rate of breathing. And the correlative discharge part means when you're actually slowing down your breathing, that motor output you're getting also mirrors onto the sensory parts of your brain. So your brain thinks you don't need as much effort to keep breathing. So less rate of breathing, less strain breathing makes you think that, hey, I'm actually breathing more easily. And thus the sensation of breathlessness is reduced. That's one theory. The other theory is just more simple, which is, hey, it directly blunts the perception of your shortness of breath by binding to new opioid receptors. So there are two thoughts. Either way, we do know that opioids are quite useful for that dyspnea sensation. Evidence-wise, Cochrane actually studied this in a systematic review in 2016. They selected 26 randomized controlled trials for opioids in the use of dyspnea management. And they concluded that there's about a 0.32 point decrease in dyspnea score. These studies used anywhere from 5 to 30 or morphine equivalents daily. They found there was no evidence to support nebulized opioids, and that most studies happen to use morphine. It doesn't mean that you can't use other opioids, whether from oxycodone, Dilaudid, fentanyl. It just means that the study protocols themselves just focus more on morphine as the opioid of choice. Most of the side effects in these studies overall are concordant with what you expect from opioids, including drowsiness, nausea and vomiting, and constipation as well. Remember that opioids, they fall under the principle of double effect. So what that means is the use of morphine to relieve respiratory distress outweighs the concern of potentially hastening any death or respiratory depression. And it's a key point to make, especially as you're using opioids, say, towards the end of life for comfort care. You may have staff or patients come up to you and say, oh my gosh, if we use this morphine drip, wouldn't that be hastening my patient's death? And using the principle double effect will help you explain that, no, the primary purpose of using opioids is really to relieve the shortness of breath, severe dyspnea that your loved one is going through. And then keep in mind that even when we use opioids, really sedation comes first. So that's almost that built-in safety where if someone's more alert and they are needing opioids for dyspnea, if they can't ask for opioids anymore when they fall asleep, like Dr. Lee had said, then they'll fall asleep first. It's only to higher dosages that really respiratory depression comes into play. So that's one way to try to balance it out. Now, another intervention that Cochrane study include benzodiazepines. So we think that benzodiazepines help with reducing the anxiety that comes from dyspnea. So it's kind of like your feedback loop. If you're short of breath, it's going to make you feel more anxious, and the anxiety will make you breathe more faster. It's going to also make you feel like your dyspnea has worsened as well. So Cochrane also studied 8 different randomized controlled trials, mainly focusing on cancer and COPD patients. And when they used benzodiazepines, they found really wasn't beneficial for the relief of dyspnea itself. So they could consider using it for a second or third line treatment when opioids and other non-pharmacological options we talked about, including the fan therapy, mindfulness, things like that, haven't been successful. So basically what they think is these benzodiazepines may reduce the anxiety from the dyspnea, but not the sensation of the dyspnea itself. So You can still use them together with opioids. Just watch out for any compound sedation side effects. Some things we commonly use would be lorazepam because it also comes in a concentrated liquid form and it's short acting for 4 to 6 hours. Other forms that are longer acting, Klonopin, clonazepam, comes in a pill form. It is longer acting. It may be more useful for chronic anxiety, for example. Um, Other things you can use, so to go more into the breathe mnemonic, bronchospasm, using albuterol can be useful. It's particularly useful also before using any mucolytic agents such as N-acetylcysteine or mucomyst because it helps prevent the bronchospasm happening when you use mucomyst, which we'll talk about later. Hours for rouse, so if they have consolidation from pneumonia and is within their goals of care, then of course you can try treating the pneumonia itself with antibiotics or antibiotic treatments, plus or minus steroids as warranted. For example, if they're in a COPD exacerbation. So just know that steroids themselves don't seem to help dyspnea. Cochrane also studied this in 2019 and didn't find much benefit from steroids itself. Effusions. So effusions can be treated well. So in the palliative space, we oftentimes will start with serial thoracenteses. So whether it's from lung cancer, more commonly from pleural metastases to the lung, it may create a lot of fluid and pleural effusions that accumulate. So serial thoracenteses are usually favored first, especially if your patient is going through active cancer treatment, because many times an indwelling catheter or Pleurex may introduce more risk of infection long term. As they progress, as their goals change towards more focus on symptom management, less on active treatment, if they're getting to the point where the prognosis is more limited and they may benefit more from riskier intervention like a Pleurex catheter, that's where a Pleurex is really useful. You'll see it often in the home-based palliative or home hospice setting. And interventional radiology puts in a catheter that's connected to a home drainage system that patient or family can use themselves to switch out the drainage bags and then drain out the fluid at home. So that can help a lot too. It saves them from having to go back and forth to clinic or the hospital setting to get serial thoracenteses, particularly if their functional status is lower and they're getting more and more homebound. Guru just asked, does the Pleurex come with the risk of worsening protein energy malnutrition? Good point. If you talk to most of our pulmonologists, they are worried about placing a Pleurex earlier in the disease process because if you drain a Pleurex out very frequently, we're talking about 2 to 3 times a week, then there can be a loss of albumin from the pleural fluid too. So if you're using it for a long term, there is that risk of protein and calorie malnutrition. Usually, though, that's why we see the Pleurex is more so towards the later stage when, in many cases, with their underlying cancer, they're already going through an anorexia cachexia syndrome. They're already having low protein states. And so after discussing that relatively lower risk now with losing your albumin, the trade-off is, hey, we may have a way to reduce your dyspnea, allow you more functional mobility at home, and save you from having to go back and forth to the hospital to get these thoracenteses done, then that may be sliding that scale to the benefit of placing a Pleurex in for palliative measures. Embolism-wise, so pulmonary embolism also very common in our cancer patients. Really, anticoagulation, what I say, is mainly there to reduce further clot burden and formation for our cancer patients and to reduce the amount of dyspnea that could happen more. Sometimes it can dissolve some of the existing clot burden and make it easier for patients to breathe. That usually is more so in a later stage after they've been anticoagulated for a certain time too. But it's always worth it to discuss that risk benefit of anticoagulation. All right. Now, moving on to the second half of breathe. So with area obstruction, so there is something where you can suction out like a mucus plug, then you could use your friendly Yankauer suction to try to get that plug out. Not too deep though. There is a risk if you go too deep, you might injure the posterior oropharynx and all the soft tissues in the palate. So it's more so gentle, especially when we teach families how to do it. With other things, we commonly see lung tumors causing bronchial obstructions. So you might need to consider talking to radiation oncology to see if urgent radiation session is needed and able to reduce the amount of tumor size. You might need to also talk to pulmonology to see if tracheal stenting is an option. Just keep in mind that tracheal stenting, they tend to be time limited because as tumors grow, those stents are pretty fragile, I would say. And there's a risk of the stent just being basically crushed down by a growing tumor or just failing. So tracheal stenting really is just a temporizing measure. T is for thick secretions. So a lot of times our lung cancer, cancer metastases patients, COPD, they'll have a lot of thick mucous secretions that are just interfering with their breathing. So some of the things you can do would be nebulized saline. It's really only been studied for cystic fibrosis, so you can try to use it. 3% hypertonic saline tends to be more effective than 0.9%. But if you have access to hypertonic, 0.9% is pretty simple way to pretty much just increase the amount of humidified air and water that gets into their lungs and help with some of that mucus. Um, Other things we've tried also include mucolytics. So the mucolytics are basically medications that break up those bonds, those sulfide bonds that hold mucus together. And that makes it thinner, that makes it easier for your patients to cough up. So two things we use most commonly seen would probably be guaifenesin, over-the-counter Mucinex. The other one is actually N-acetylcysteine or Mucomyst. Again, you see it is really used a lot in cystic fibrosis, but Mucomyst can also be used together with albuterol to really try to break those bonds and to thin out mucus to help their patient cough it up. Anticholinergics are another option. So in 2008, secretions at the end of life were studied. You might hear this quirkily as um, like a death rattle, where you have secretions stuck in the back of the throat and you hear that terminal respirations or death rattle. And really, there's no one evidence to say that one is better than placebo. And oftentimes, we don't actually need to treat death rattle because patients themselves don't really feel that rattle when they're at the end of life and unable to cough up secretions. We have to treat it mostly for the family. So you treat it is mostly for family distress and comfort. If you do choose an anticholinergic, of all the ones you could, glycopyrrolate usually has less sedation compared to atropine, hyoscine, or scopolamine, because glycopyrrolate is the largest molecule, so it's harder to cross the blood-brain barrier. You'll see in hospice that atropine is used more often because it's just easier to get. They just give the 1% solution that comes in eye drop form, and they repurpose it to use it sublingually to help with that. Um, and scopolamine helps. It does have a time of onset because scopolamine comes in a transdermal patch placed behind your ear, and that will take about 12 to 24 hours to take effect. But if you need something more long-term and you don't really want to put things in sublingually, scopolamine is a good option too. Hemoglobin, and also just make sure to just remember your age, especially when your patients are on antineoplastic therapy that's suppressing the bone marrow. Anemia is relatively common in order to see that you may need to help them with a blood transfusion here and there. Yep, good vote for hypertonic saline, 3%. So what about oxygen? So now we get to this. What do you think? Do you think oxygen has a role in relieving dyspnea for our patients? You got it. Um, Really, it is most evident if they are hypoxic. So if they're hypoxic, then they are positive. You fix hypoxia, you make them breathe better, right? So they show that effect of oxygen in COPD patients, so mostly when they were active and they're exerting themselves, when they're walking around. So you might see a lot of the times that your patients with COPD will say, hey, I really just need my oxygen when I'm walking around or when I'm going to shop, but at home I find I don't really need to use it. And that's something you see pretty commonly. If you're not hypoxemic, it's really a mixed benefit, probably not much. Both British and American Thoracic Societies recommend really focusing on opioids and non-pharmacological options before supplemental oxygen. That being said, things I mentioned, it could be like a placebo, and kind of the truth, oxygen therapy is perceived to be important by families and patients. The way it's framed is kind of like when you have that want to provide food for your loved ones because, oh, I'm worried that mom is hungry. Same thing when you're looking at your loved one and think, oh my gosh, mom's struggling to breathe. We need to give her something. And so that's where if it's really just a simple nasal cannula with 2 liters of oxygen, it might just make the family feel or calm that, hey, we're providing something. And really, it's just about reframing and knowledge sharing with family. So let's say your family member, like Isabel asked, that um, I'm worried about mom's, those secretions at the back are causing her to have that death rattle. Should we do something about it? The language I would use is, as part of her dying process, she doesn't really have the energy anymore to cough up these secretions. But we find that in our patients, doesn't really bother them because they're not really aware that it's stuck there, but they're just trying to breathe it out as the way they are now. So we can do is we can leave it alone. We can do some gentle suctioning if we notice that there's secretions near the back of her mouth, not going too far back that it will cause her damage. And if your family thinks it's just really important to have a tranquil setting so that these secretions aren't bothersome to other people in the room, we do have medications that we can use as needed to help with some of these secretions. And that's what I would say, just reframing it to make sure that um, we know that the death rattle, the terminal secretions that we see, they're a normal part of the dying process. I think that normalization is really important for families to understand. This is part of it, and we don't have to treat it. If we do, then we can. And just to delve into the oxygen therapy, just I was really curious about it. It's really limited use. Like they've studied it, they've tried to look and see if oxygen really had benefit. If you look at one study from 2010, they basically had a nasal cannula and they either put oxygen or just room medical air at 2 liters per minute for 1 week with patients with cancer, COPD, and refractory dyspnea. So they said that really there wasn't any symptomatic benefit of oxygen over room air for dyspnea because both actually kind of decreased. On the other hand, another study in 2012 that was double-blind study also had serious ill patients on oxygen. In this case, they just gave it either room air, oxygen at 1 to 4 liters per minute, or just no flow for 10 minutes for 6 cycles. They really focused on those with poor prognosis of a PPS of less than 30%. And overall, there's like no change in respiratory distress. So keep in mind though that it was only done for 10 minutes and it probably could have been done for longer, but I think the goal is at really the end of life when they're actively um, dying, it probably wouldn't help too much because their bodies are already shutting down. But then I would postulate that, hey, like, how do you define the end of life? And I think the timing of it is important. If you use oxygen at the very last hours, days, even weeks of life, you're probably right. Probably is a limited use. But then if they have weeks or months of prognosis, and especially have hypoxia, then it could be of some benefit. And remember that, that can apply for hospice too, because patients with less than 6 months prognosis, we could be talking about patients from the very end of life to even the beginning of their hospice journey. So it's important to just keep in mind that there are certain scenarios where you could tailor how you provide the oxygen to patients. As long as they're providing some symptomatic relief, I would say it's useful, whether it actually helps with hypoxia or it's more so to provide that uh, comforting effect for the patients and families. So just to go quickly, standard oxygen therapy, all of them deliver some amount of FiO2 to patients, whether you choose nasal cannula, 1 to 6 liters, a face mask at 5 to 8 liters, or a normal breather from 6 to 15 liters. Usually, this manages a low flow oxygen therapy. There's a lot of mixing, so there's a lot of systems are leaky and not airtight. And if we do really high rates of it, it can lead to the nasal passages drying out too. So different ways to humidify it if you can. Some of them also use an oxidizer pendant, which can help deliver some more oxygen to your patients. Just to know that there is more use of high flow oxygen in palliative care and hospice. We in Kaiser Permanente are also trialing this too. We're trying to provide this particularly for an inpatient to hospice setting. And why can this be helpful? Because it is more comforting for many patients. It's humidified, it's warmed. There's usually less trauma to the face compared to someone using BiPAP. And it can still allow someone to eat or drink compared to someone on a face mask or a BiPAP mask. So this became more prominent after, well, yeah, after the COVID-19 pandemic in 2021. And I think a lot of patients needed that to get home safely from inpatient to home, particularly when they were dependent on high FiO2 needs. So you might start seeing this more. Just keep in mind that there is a limitation because you really it's really hard to get high flow to the home setting because all these high flow machines were really meant to be used in the inpatient or the home setting. So you need a like even a advanced ambulance to transport it with enough oxygen to deliver it. And really only a few companies, a few governmental organizations have that capability, such as when Paris did that with their fire brigades too. So probably logistically hard for many people to do. Just something to keep in mind that you're not just limited to 15 liters or less, say when you're transitioning someone from inpatient to the home hospice setting. All right. Any questions so far? Or just get into a bit more about palliative extubation? All right. Now, with palliative extubation, I think it's going to be a procedure. It's a procedure with preparation, with topical of care conversations with these patients. I think something that it's related to how we manage dyspnea and something that you'll be practicing throughout your fellowship. And we really are trying to optimize someone's quality of life while allowing their underlying illness to take their natural course off artificial life support. So the way we divide it up would be there's preparation before the exturbation, preparation during it, and then knowing how to handle it post-extubation as well. So really, a pre-extubation is providing as much anticipatory guidance for someone's loved ones as they need before the extubation happens. So a lot of it is really down to assessment, like making sure that you've talked to them thoroughly about what their patient's goals are, using different frameworks to communicate bad news, explain their current state, their poor prognosis, and exploring whether ongoing artificial ventilation is really in line with what your patient would want. It's a great time to use our interdisciplinary team, making sure that you have chaplaincy support, social work support, nursing support, to make sure that we address any of the spiritual, cultural, or personal family practice that should be honored. I can tell you even yesterday, I helped with a palliative wean off BiPAP for a family. And one of the spiritual importances they put was they took off my patient's slippers and they washed her feet. And that it was really important for mom to have her feet clean because she's preparing to go up to heaven. So we want to make sure that she's comfortable and that she's ready for that journey. So a lot of different families, a lot of different religions will have these really, really important tasks that they want to do, whether they're it's as simple as washing someone's feet, whether it's having a chaplain coming in to deliver last rites before. You want to make sure that all that can be addressed and provided for the families. I think another important point is making sure that the families know just how much do you want to know? Because, like Mel said, if they're not ready to receive that information, you can always come back and readdress it again when they're more ready to hear more. If it's just been too much information for them, they're not in an emotional state to receive it well. But I think knowing, giving them information on how will this look like with the extubation, what to expect afterwards with the dying process, and what are the stages of dying that they may see as a loved one transitions, that can be really important for them to know. As far as your role with addressing and explaining it, I always emphasize that you're not withdrawing care. And I made that mistake too when I first started by saying that we're going to withdraw care. You never withdraw care. It's always about providing the best care possible throughout this process. So what we're really doing is we're just stopping the ventilator support. We're stopping these tools that are keeping your loved one in the state they're in, and that we're allowing a natural process to happen afterwards. Really, powder extubation is ethically and legally different from euthanasia or physician-assisted suicide. You know, which we talked about when you do this appropriately, it's different than uh, uh, helping someone die with medication. Because when you do appropriately, use opioids as much as you need just to relieve dyspnea, but no more than that. You don't use very high doses of opioids to hasten death, to purposely slow down respiratory rate. You reassess, you use more if someone has dyspnea, and you adjust medications as needed. And really, when you disconnect the ventilator, disconnecting it isn't itself the cause of death. It's the underlying illness that's causing the respiratory failure, that leads to death eventually. Other things you want to check with your team would be making sure that if there are things like ASCDs that need to be deactivated, they should be done before palliative extubation. Making sure that if they're on other medications like dialysis or vasopressors, that ideally they're stopped soon before, so that they're not so much in fluid overload or then other causes that could hasten death, but they stop them right beforehand so that they're not putting undue burden during that process. And then also setting a date and time is important because you want to make sure that families around. What I like to do is have it done early in the morning when you have a whole daytime team to help with nurses, with respiratory therapists, and you want to make sure that family is all there, that anyone that wants to be there, that should be there, is there. Because after you palliatively extubate, your prognosis is pretty limited when if they're at the point where they needed to be intubated in the first place. So you anticipate a prognosis of likely minutes to hours, sometimes hours to days, depending on how much reserve they have. But you want them to be around when the patient passes away. Really for medication management, it's a lot of similar things we talked about, really using opioids, potentially stopping antibiotics, using benzodiazepines, considering secretion management with anticholinergics, with or without steroids, and also seeing is there a role to stop diuretic, stop antiarrhythmics, for example. Steroids are a good part too, because a lot of times when you're intubated for a prolonged period, that endotracheal tube can cause a lot of laryngeal edema. So you want to reduce any of that kind of that rattling noise or secretions that cause that terminal secretion sound. Steroids given at least 4 to 6 hours before the extubation can help calm some of that laryngeal edema and reduce that terminal rattle. For medication was just remember that you assess the need, whether this patient needs an opioid drip to post-extubation breathlessness. These patients may not have been using many opioids beforehand for pain or dyspnea when they were intubated. They were likely on sedation and likely really not really showing any need or for comfort medications. This is one of those cases where an opioid drip started beforehand is usually helpful because you anticipate that when you're going from being on a ventilator with ET tube support to nothing or to 2 liters of nasal cannula, you expect there to be some serious dyspnea that you want to start controlling with an opioid drip beforehand. You want to at least start it at least a few hours beforehand. It takes about 4 to 5 half-lives for an opioid drip to reach steady state. So at least 4 to 5 hours, preferably 8 hours before, to make sure that that opioid drip is at steady state and is actually providing relief for that patient. Remember to consider other alternate opioids like fentanyl, methadone, particularly if they have end-stage renal failure, and make sure to discontinue any paralytics that may be on too. For secretion management, we talked about dexamethasone or other steroids to decrease laryngeal edema. You could also think about using your anticholinergics like scopolamine or glycopyrrolate, and then consider all those. So just quick thing about opioid pharmacology. Remember, it's usually about 4 to 5 half-lives. Get that opioid drip to steady state first. And then you want to also have an immediate release of opioid too, because when you have the opioid drip, then that can help a lot with maintaining it, but oftentimes may have dyspnea that's uncontrolled. You want to make sure that they have some immediate release as well to help control any dyspnea that happens after. While you're in extubation period, I always like to talk with the nurse and the RT at bedside. Make sure that we're all on the same page in terms of how to do the weaning off the ventilator. We give you 15 to 30 minutes before, give a bolus of opioids, and you can choose to give a bolus of anticholinergics if you're worried about that terminal rattle, and also anxiolytic like Ativan beforehand, just to make sure that you have a nice amount of opioid and anxiolytics in the system before you extubate. And when you're in the room, make sure to talk to the RT about, do we need to titrate the ventilator settings to something more gentle? Because this is your time. If you need to make sure that, hey, I'm not sure if my opioid drip is at the right dose yet to really help with this patient's anticipated dyspnea, you want to take that time to work with your RT, work with your nurse, and ask them, hey, we started with 2 milligrams IV morphine. Have they been less dyspneic on it? Do you think it's enough to calm their physical signs of dyspnea down? Usually, if they're You want to make sure that their FiO2 is 20%, their PEEP is less than 10, chest or cuff, make sure to suction, to make sure there's no mucus in the tube, and you get all that ready before disconnecting the ventilator. If they're using higher PEEP settings, high FiO2 settings, you might want to consider talking to your RT about doing a stepwise reduction. So you go down from the higher FiO2 or PEEP settings on the ventilator, step it down. And at each step, watch their patient for 10 minutes, see how they're doing on those settings. If they're showing more signs of dyspnea, subjectively with the grimacing, use of accessory muscles, more catypnea, then you might need to give an additional dose of the opioids or even considering increasing the drip if you need to. And then once you, RT, and nursing staff feel, hey, we have a good control over this patient's dyspnea, then you can proceed with palliative extubation. Afterwards, once you extubated, then you want to just give additional medications of PRN opioids or anxiolytics as needed if they're still on pressors because we're really waiting for family to all arrive and keep the patient at a stable cardiopulmonary state before you extubate. That would be the time to discontinue. And then just wanted to stay around until you make sure that that patient is comfortable, they're not in active pain or dyspnea, and then update the family on what to expect after with terms of prognosis, in terms of what to expect as the dying process happens. Afterwards, just make sure that all the medication that your nurse needs are ordered, review the treatment plan with the team, give guidance to the nurse. If these boluses are ineffective, you've given multiple ones in a span of a few hours, and he's still having shortness of breath, then what do you do? How do you contact the palliative care team? How do you contact the overnight doctor if it's after hours? So things like that you want to discuss. And then that'll be your time to really talk about any questions and answer them from the patient's loved ones. Similar thing, you just want to monitor the opioid drip, follow principles of opioid management with increasing drip rates. If there's more than 3 or 4 dosages within a few hours, that's a sign that your drip rate may need to be increased, or that you may need to evaluate if your bolus dose of opioids are adequate to relieve dyspnea. You might need to consider giving additional dosages of steroids or anticholinergics if they have a lot of secretion still. And oxygen supplementation, really, if you want to titrate nasal cannula to comfort, whether it's actually helping or it's more so for family perception, I think at that point it's pretty low risk maneuver that you can probably do pretty easily. Otherwise, make sure to control delirium, anxiety, agitation, control any nausea they may have, secretions, and then fever, if they have any fevers. Usually many places have, whether on hospice as a comfort kit for management of all these symptoms, or it might be even in your order set for comfort care if you have these medications on an as-needed basis. Make sure to continue spiritual support and social worker support if the family needs it. Remember to don't forget your little things like eye care, oral care, lubricating eye drops, and oral hygiene is important too. Repositioning, a lot of times if they need to be repositioned, that's fine. Many patients though, will just prefer to be just don't bother me, leave me be. Repositioning won't really help with preventing terminal ulcers from forming. And really just monitoring. You want to minimize vital sign checks because it's helpful for privacy. And if you can, turn off that monitor in the room because what happens is a lot of times family will just perseverate over looking at the decreasing pulse ox numbers or the heart rate. And really, we can monitor from outside the nursing station, but for peace, just disable that monitor inside the room and just reassure them that we'll cover it, we'll monitor it. Otherwise, for monitoring, as we talked about before, you look for signs. And when the patient can't tell you if they're short of breath, then you look for other signs, grimacing, moaning, fidgeting, or signs of agitation, use of accessory muscles, nasal flaring, or grunting at any expiration. Usually you distinguish this from Shane-Stokes breathing. So Shane-Stokes is when you have those pauses in breathing, and then you have the resumption of breathing after a period of apnea. That's part of the dying process that you want to talk to your patients about so they know that that's a normal part of dying. Or even mandibular breathing, where you have mandibular gape when your mouth is more open because you just don't have the energy to close your mouth anymore. Limit vital sign checks. Generally, if you're checking the monitor, I try to keep the respiratory rate below 30, heart rate below 100 as a general sign of distress. And then we continue our care until that patient has passed out. So that's it for that. Latasha asked, is it common for palliative care physicians to extubate patients in the hospital setting, or is this typically managed by the intensivist? It depends. I know in our institution, it's mostly intensivist actually, but there are some cases where they would like the palliativist to step in and help with talking to the family before, during, and after, because we do provide more of that supportive role with our teams. So I think it really depends on your institution. We've seen it here in a lot of our hospitals that our intensivists have liked to have the palliative care team involved for the goals of care beforehand, especially when you're navigating towards, is this case appropriate for palliative extubation? So because the palliative care team has been involved already, it's a more natural process to keep being involved for the extubation part too. Because every system's different, I think it's a good skill set to know of in case you're called on as an attending to help manage this so that you know how to counsel patients and how to manage it well. All right. I think that's about it. All right. Anything else?
Yeah, to add on to Latasha's comment while Jason reads Carly's question, yeah, it's so institution dependent. Sometimes actually I'll stop the recording while I'm thinking about